We're talking persistent post-concussion symptoms and FND, the overlap, what's similar, what's different, an article review today. And my name is Julie Hirschberg. If we haven't met, I'm so excited you're here, you're listening, you care about this stuff. I am a neurologic physical therapist and the owner and founder of re+active Therapy and Wellness. I'm in the Los Angeles area. I have the great honor to lead a team of PTs, OTs, psychologists, neuropsychology, yoga therapy, fitness instructors, to work with people post-concussion, to work with people with FND, and sometimes both of those things. There's certainly an overlap. And so when I saw this paper published, so let me actually bring up the title of it for you. Post-Concussion Syndrome and Functional Neurological Disorder, Diagnostic Interfaces, Risk Mechanisms, and the Functional Overlay Model. I was just super stoked to see this all together because, to be honest, we see some overlap, certainly clinically. I hear about this from other clinicians and from physicians as well, and there's just not a lot that has been researched. And this is a review article, so this is not a randomized controlled trial. This is really looking at broad topics and multiple different studies to look at where these things interface, where they overlap. So I want to go through the article. I also want to say, hey, I actually don't agree with all of it. And I had a really lovely person share her thoughts as well, sent me a message, and I was like, yeah, there are some things, I have a bone to pick with a few things in this article, but I think in concept, it is answering or attempting to answer a clinical question that many of us see, which is this overlap. So let's talk about this article. I have lots of figures from the article as well as some other pieces to share with you as we explain and go through this, and I welcome your questions. And in fact, some folks sent me questions ahead of time, so at the end, I'm going to go through the questions that have been submitted as well as the questions that you share with me live to the best of my ability. Obviously, I can't provide personalized medical advice at all, but I can share my curiosities and what I know and learned. And hello. I'm so glad for all my clinicians here. This person sharing, I have a case and literally treated a patient an hour ago and struggling a little bit. So thank you. I'll read the article. Yes, read the article. So this just got published in July of 2025. It's only August 6th. So this is hot off the press. It was published in Brain Sciences. The lead author is a neurologist who is in a clinic. So by the way, if you're in the UK, he's in Leeds and in London, and has a clinic that sees people with neurologic disorders, post-concussion, and FND. So this is coming from a person who has experience in multiple realms, which I think is great, and obviously a whole group of folks. So if you're a clinician, you have likely seen the overlap of these pieces. If you are a patient, you might be wondering, like, I had a concussion way back when, or I had a concussion and then I developed FND. How are these related? We're gonna kind of talk about how they might be related and how they're not related too. So what are some of the differences? And so I'm gonna take this down. And by the way, if you're on our newsletter, I will send out a link to this article and the other articles that I reference in this live today in our newsletter. You can sign up at reactiveeducation.com if you're a clinician. That comes out every Friday, or reactivept.com if you're a patient. That comes out every Monday. I will put all of the links in the newsletter. Okay, so let's dive in. In the introduction to this article, they talk about how common these conditions are. If you're not familiar with persistent post-concussion symptoms, or what some people call post-concussion syndrome, or PCS, it is recognized to occur after a traumatic brain injury or TBI, and there are very common symptoms, things like headache, dizziness, mood changes, anxiety, cognitive changes, They don't mention this, but autonomic dysfunction is really common, visual symptoms. All of those can be part of a post-concussion syndrome. Now, if you work with folks with FND, or if you have FND, you might be like, well, I don't have any of those symptoms, or you might have some of those symptoms. So it's not that these two disorders are exactly alike, and that's actually why these authors did this really nice article review, and why I think it's important to take a look at this. And clinicians, I'm going to tell you those things that are like in this article that I think they're important findings, but they're not everything. So I like stay tuned for this discussion on the things I don't agree with, because I really want to talk about that. What can occur after concussion is that a person can have really long persisting symptoms years, 20 years later. And those are people that I see, right? And at this point, the acute injury has subsided, but the symptoms have persisted. And the question is kind of why, right? And so similarly, in functional neurologic disorders, we can get symptom presentations for a very long time. And in both of these, which we're going to talk about in when they compare and contrast these, there's some distinct overlaps in some of what's happening in the brain in people. So let's talk about some of the key characteristics. And I think, let's see, I have my first table here. Let me grab this. So one of the tables is right here. I think, oh no, that's table 2. I'm sorry. They all look alike and they're kind of small on my phone. Table 1. Okay, so table 1 is looking at the clinical and diagnostic features of post-concussion syndrome, or FND. A subtype of FND is functional cognitive disorder, where it's primarily cognitive symptoms. And that's a type of functional neurologic disorder that can really mimic the cognitive symptoms that show up in persistently after concussion. So what you can look at here are the key pieces: the etiology, the symptoms, the objective findings, the diagnostic criteria, the neuropsychological testing. This is a really important piece, I think, when it comes to cognition. I wouldn't hang my hat on a diagnosis either way, or cognitive deficits due to either of these diagnoses without neuropsychological testing. Personally, I am biased because we have an amazing neuropsychologist on our team who can do this testing and can help really tease out what is brain injury, what might be a functional cognitive disorder. And I think that's really helpful. And regardless, cognitive rehab can be very, very helpful. And so if you're a person with persistent symptoms, either from concussion or from functional neurologic disorders and cognitive symptoms like brain fog and memory difficulty and thinking and executive function, I do know those can get better. I want you to know that. I'm not your person. Physical therapy is not your person for those cognitive symptoms. Neuropsychology, speech therapy, really, really beneficial for people. Okay, so if we look at some of these key differences here, a person with post-concussive syndrome, they've had brain trauma. They've had a concussive event, a TBI, and the person with FND has not, unless of course they developed FND after concussion, because we know FND can develop after an event, or after kind of a constellation of events or things happening. So for example, it could occur after concussion. FND could occur after a foot injury. What we know is that what is actually causing the symptoms is not the foot injury, but functional brain network changes. Now, it turns out in prolonged persistent concussion symptoms, there's also brain network changes and they're quite similar to FND, and they talk about that in this article. So I think that is important to note. Some of those brain changes, those network changes, are similar when somebody has persistent symptoms. I'm not talking about acute symptoms. The symptoms can be different. So the person with post-concussion syndrome typically has headaches, dizziness, fatigue, cognitive difficulties, some mood changes. We might see some cognitive difficulties in FND. We often see fatigue. We can see dizziness, but we might see more movement disorders, sensory changes, functional seizures, maybe even disassociation. But you can see some overlap in the symptoms here. The objective findings. So typically there's normal imaging in both. And now in post-concussion, there can be some subtle changes, maybe on DTI or fMRI. We are actually seeing those things on fMRI, potentially in FND. There's not a clear marker yet for that. But what FND has that concussion does not have is some positive functional neurologic signs on exam. So a clinical exam that can support the diagnosis. A person post-concussion should not be given the diagnosis of FND without having positive clinical signs of FND. So there are clinical signs for visual changes. There are clinical signs for weakness. There's clinical signs for tremor and dystonia and seizures. So those clinical signs would depend on the symptoms, but the person shouldn't just be like said, oh, well, you have FND, just because their symptoms are complicated. That's not how it works. So objective findings, diagnostic criteria, we have clear diagnostic criteria for both. However, FND actually has these really sensitive and specific positive clinical signs, and the persistent post-concussion symptoms, that's just what they are. They're kind of a constellation of symptoms that occur after a concussion, and there are not, now we have a lot of clinical tests, but they're not necessarily like, oh, a positive, we use the VOMS, right? So it's a visual and oculomotor function test. Like a positive VOMS doesn't equal concussion. So we don't have those positive signs like we have in FND. But we have a mechanism, right? So clear mechanism leading to those symptoms. That neuropsychological testing, as I mentioned, super important. It's the variability. I think the variability piece is such a big component of FND, where you can see maybe even like normal or even very high test scores on neuropsychological testing, but that actually is way different than what that person can do in a day-to-day setting, for example, or the subjective complaints. Biomarkers. So this is really interesting. In post-concussion syndrome, there are a couple of biomarkers that are elevated in the very acute phase. It's hard because I know oftentimes as clinicians, we might see people really like post-acute, but there are some exploratory testing looking at other things like inflammatory markers. There's exploratory testing actually in FND as well. There's been some studies with cortisol, but autoimmune, inflammatory. But these have not been established for either diagnosis. So those alone won't be the thing that really tells us one or the other, if that makes sense. So that's what I think that's like a real positive of this particular review, is to just look at those side by side. What are some things that are similar? What are some things that are different? Now, the first thing that I would say that maybe goes wrong in this study or in this review is a very strong emphasis. So they take this biopsychosocial approach, looking at the biological, the psychological, the social contributors to a person's symptoms, but they highly emphasize the psychological piece. Now, they do make a statement to say, hey, neither FND nor PCS is a psychological disorder. It is not. That has been shown. It is not conversion disorder. It is not purely psychological. But then they go on to talk about 4 pages here. I'm just kind of scrolling through. Gosh, maybe the majority of the article is about those psychological factors. Now, here is what I want to say from a take-home standpoint. We have to understand neither of these disorders are entirely psychological. We also need to understand that most health conditions in any part of our body, whether that's the brain, but especially the brain, but every health condition is influenced by psychological factors. That is like without a doubt. And in this particular study, they dive into the specifics of which psychosocial factors can influence outcomes, really, and prognosis for these 2 groups. So they say, hey, this is not a psychological disorder, but psychological pieces can influence the outcome. I think they kind of overemphasize that. And honestly, and I'm not a psychologist, right? So I'm a physical therapist, but I'm also a person who lives with a chronic illness. And a lot of these like psychosocial risk factors and traits, I'm like, oh yeah, that's me. They talk about perfectionism. They talk about neuroticism. And I just, not being a psychologist, so this is like, and I know I have amazing psychologists on our team. I really wanted to look at what were these studies. So this is a little tangent, but these are for all my other clinician friends and for patients as well. What are they looking at when they say that there might be a higher trait of neuroticism in people with persistent symptoms, post-concussion or FND? And I was like, well, are we all neurotic? And so I actually had to look at the big 5 personality tests and look at like, what are the neuroticism scores? And I was like, okay, well, I'm clearly neurotic here. Here are those questions. And I think this is the thing that is really hard in chronic health research. You might do these profiles and find something, but how much of this is actually because you live with a chronic health condition? So for example, one of the like traits for neuroticism, get stressed out easily. Like, if that's you, raise your hand, right? Like, yes, I too get stressed out easily. I'm a mom and amongst many other things. I'm relaxed most of the time. So the neuroticism, I'm looking at, it's like several of the questions like built in here. But basically, I'm pretty sure I'm high on the neuroticism part, which if I had a concussion or if I had something else that led to functional neurologic disorder, in the literature, this trait of mine that I have would, this trait that includes things like worrying about things. These are some of the other questions. Mood swings, I don't really have mood swings, get irritated easily, often feel blue. These, if you're high on this trait, you might have more symptoms, although it's not always directly correlated. I think the take home, so sorry, that was a little sidebar because these authors really went kind of on and on about the personality traits. And I don't want to ignore personality traits, but then it just got me curious, what are these questionnaires that are kind of maybe labeling somebody as anxious or depressed or neurotic? I mean, I'm familiar with the anxiety and depression scales, but I wasn't familiar with this, so I had to look at it, and sure enough, I'm sure many people living with a chronic health condition actually might fall in that category. However, so that's just like, take this piece as part of the really like big picture piece, right? And so although they talk about these psychological and personality factors, it's not the only thing. And what is important to look at is these are also part of, there's other pieces that are connected, right? So they talk about interoception being connected, and that has been shown highly in FND to be related to symptoms, as well as those brain areas that are affected. So this first part, so I think this is kind of part 3 of this article review, talks about personality traits and risk factors in post-concussion syndrome, in FND, the psychological profiles, including anxiety and depression, and the risk factors for these things. I want to answer a question here, that came up as well. So Allison is saying, I had a TBI in 2020. I was diagnosed with FND in 2021. My primary symptom was lower body paralysis. In 2025, I had another TBI, now experiencing functional seizures. My question is, could the TBI cause FND? This is a great question. And Allison, I do think this is part of what the authors were getting at is, yes, the TBI can be part of the precipitating factors for causing or contributing to a functional neurologic disorder. So yes, could lead to the development of a functional paralysis, could lead to the development of functional seizures. And this is where, and the authors recommend that a person really have an individualized, and I'm like zooming out here, kind of whole person approach to understand how and why this might have occurred, or what are the overlapping pieces. And so, Allison, when I see people who have had a concussion or brain injury and have developed FND, I am wondering about the whole pie chart there. Autonomic is a really big one, especially I think of that as a really important factor in thinking of functional seizures, and it's impacted by brain injury. The sensory system is a really big piece, and the authors do talk about the sensory system. They leave out autonomic, so that's the other bone to pick I have about this. They don't talk about autonomic at all. It's a really important biopsychosocial component of both of these disorders. They talk very, very briefly about sensory. Motor control is important, and they do hit on the predictive brain component of this. And this was a nice overlap that I think that they talked about how psychosocial factors can also influence the predictive brain. Interoception abilities influence the predictive brain as well. So I think they did a really nice job talking about it. The psychosocial pieces, lifestyle pieces, like physical impairments, the whole pie chart. This is where, when it comes to treating this as a clinician, I don't treat a diagnosis. None of us treat a diagnosis, right? We work with a person, and we want to understand what is happening for that person. And when it comes to FND, when it comes to persistent post-concussion syndrome, we really need to look at the big picture, where they might overlap and what might be most contributing to their symptoms. So really fabulous question. And I think, let me pull up the question. There was another question that came up similar that somebody had sent before, which was, why does post-concussion lead to FND? Can both be treated simultaneous? So not everybody after concussion develops FND. And what the authors talk about in this paper is that, like, essentially you can have both. Now, I'm getting ahead of myself, but why don't I just get ahead anyway? They talk about this idea of the functional overlay model. I actually disagree with this. So I would say if somebody has positive clinical signs of functional neurologic disorder and had a concussion, they have both concussion and functional neurologic disorder. We don't need to say they have a concussion and a functional overlay, like it's like, I don't know, like a t-shirt you're wearing or something like over your concussion. No, like you have both things. Because not only with concussion, but a lot of neurologic disorders can develop FND with them. Parkinson's is a common one, MS, those are probably the most common, but migraine, we see it autonomic disorders as well. And so I don't think we need a model. We don't need a functional overlay model. I think we just need to like say what it is. You have a concussion and you have FND. Now here is where I would say what really would be helpful is to go, here's where they overlap. They overlap in the autonomic nervous system. They overlap in the sensory systems. They overlap and actually test those out, right? So test those out in a person. Let's test your autonomic function. Let's test your sensory function. Let's test your motor control. Let's look at your lifestyle. Let's look at the psychosocial factors. Let's not ignore that they could influence things, right? Let's look at the physical body. Now, this is another thing, you know, these authors said, let's look at biopsychosocial. They ignored the body completely. Like there was no mention of like neck involvement, which we see a lot post-concussion, and we can see that in FND. Hypermobility, there was no discussion of that either. So two very body-oriented things that were just not in here, which, you know what, I totally understand. There was a lot that they put in here, and they kind of emphasized two major pieces, which was the psychosocial and then some of those like biological markers. Honestly, because they're physicians, like these are the pieces that they're looking at. And we as rehabilitation professionals, so PTs, OTs, speech therapists, psychologists, we're going to kind of look at, well, this person's having trouble walking. This person's having trouble with looking at the screen. They're having headaches. Let's figure out what is contributing to that. And that is looking at like all the pieces together. Really like in a pie chart fashion is what I would say. Okay, so I talked about part 3 in this article, which was some of those overlapping factors. Then they go into predisposing factors. And what's really important here, and that I'm so glad that they did, is that they mentioned that autism and ADHD are actually common components of functional cognitive disorder, and that this might be related to some of the sensory processing that lead to predictive coding impairments. I was just like, hallelujah, that somebody is saying that in there. And again, they're summarizing the literature. I've talked about these studies as well, but I was just really happy to see that in there, that they're identifying that this can be a predisposing factor. And this is something that we can like intervene on the sensory system level. We're not going to change, we're not trying to change a brain. Like we're very neurodiversity affirming practice at Reactive. I think all clinicians should be that way. We're not trying to change somebody's intrinsic brain, but we're going to support their sensory system. We're going to figure out what they need. And so I was really glad they said that. Now, they did not then say working with like OT or PT or speech would be really helpful. Like they really kind of identified psychology, which I believe every person in the world should be working with psychologists. It's probably like my favorite appointment every week for myself. And it's so very important, but it's just not the only thing. And especially when we're talking about some of these sensory processing pieces, like people should be working with OTs and speech therapists and physical therapists in addition to psychology. So they talk about predisposing factors like that, precipitating factors. So obviously in a concussion, it's the head injury. In FND, it could be a head injury. It could be a foot injury. It could be trauma. It could be related to grief or stress. And they talk about those as potential precipitating factors. One thing that I thought was, I was really happy for them to comment on, is things that can perpetuate and make the symptoms worse include, I mean, there's many things, but they include social factors. So social isolation, support from friends and family, are all things that can really perpetuate symptoms. Not saying they cause the symptoms, but this really, really to me as a clinician, calls for us having a community of support for people when they're on a healing journey from concussion or FND. Okay, so I want to pull up here table 2 because it has the risk factors. All these tables look the same here. I hope that I got the right one. Yes, tables, shared and distinct risk factors. So you can see along the side what is shared between these. So some of the risk factors include being female, yay, us, having a prior psychiatric illness, certain personality traits, but I would argue, did those come before the illness or after? But trauma history, multiple concussions, and so on. So you can see where those risk factors are shared and where they are distinct as well. But there's clearly overlap for these pieces. And then they have a nice little diagram here that is looking at all of the pieces: predisposing, precipitating factors, personality profiles, perpetuating factors, and some of those pathophysiological considerations. But there are things missing here. So they call this a biopsychosocial model. There are some biological pieces in here because they're talking about some of those network changes like attention, dysfunction, and some of those predictive coding anomalies that occur. But we are heavily missing autonomic dysfunction from here, hypermobility, neck injuries, lifestyle factors. This is primarily a psychosocial overlap that they're converging on here. That's not a bad thing. There's just more, right? There is just more. And perhaps they're really writing this for a psychologist. And so maybe this is why I struggle with their what I would say overemphasis on the psychological piece. Maybe they're really writing it for the psychologist to go, look at these pieces, look at all of these potential areas where you could really help somebody. But I think because of the stigma associated with functional neurologic disorder as primarily a psychological disorder, and even though these authors actually really clearly state it is not a purely psychological disorder, they then go on to put only the majority of the psychological things in the diagram. It's concerning. It just misses some of the picture. But there is still so much good. There's still a lot of good in this because part 5, so a lot of that beginning part was heavy on the psychological personality components, where they differ and where they're the same. The last piece is on that biological piece, that neuroimaging, the biomarkers. And let me just pull this up. This is, just as like a neuro nerd, this really, it really interests me. I mentioned just a little bit about the biomarkers because we have more biomarkers in acute post-concussion syndrome than we do in the chronic phases. And there's a lot that's unknown in FND. So this is really when it comes to chronic pieces, this is an area that I would say is still really under research. We don't have a lot to go on here, but we've got some things in the acute phase of concussion. But when it comes to the brain and those network connection issues that we know go awry in FND, it's very interesting. And in fact, they say interestingly, the prefrontal cortex, limbic areas, and parietal regions implicated in FND overlap with the regions affected post-concussion, particularly when there's persistent complaints. So both disorders show disrupted functional circuits involving attention, emotion, and executive control. And they suggest, and this is not surprising, like I've read these separate literatures, it's just nice to have it all together. This suggests that there could be some shared pathophysiologic component of the network dysfunction, even though they have different causes and even different symptoms. Some of that network dysfunction that we see in both of them could explain how these symptoms occur, even if the symptoms are different. And then they go on to say this: crucially, these insights advocate for integrative diagnostic models that go beyond organic versus non-organic classifications and toward an appreciation of brain network dysfunction as a shared terrain in both conditions. Clinicians, we should be like shouting hooray that we're going to get rid of organic versus non-organic. It's very, very old, okay? Like that is old. That's what I learned in school, and I'm old, and so that is old. That is no longer the case or the understanding in FND or persistent post-concussion symptoms. That is like one is organic and one's not organic, one's real, one's not real. It's all very real and it's all very organic. And it's not like, oh, well, you had a concussion and then you had this psychological phenomenon of FND occurring. No, you might have had a concussion and in your particular beautiful brain, you developed or you had this network dysfunction in these particular areas, some overdeveloped, some underdeveloped, and it's causing and perpetuating these symptoms. And that is really important, and that is in both disorders. And that is something we can treat. That is absolutely treatable in both persistent post-concussion symptoms and in FND, because we can test out those attention networks. We can look to, the default mode network is kind of like overly activated. We can do activities to decrease that, increase the salience network by doing goal-directed activities and really help people get better. And I think this is really, really important. Something else that they write in here, they said, the clinical aim is not to establish between real, like concussion, and functional. That is not a distinction. And they say, but rather to adopt continuum-based view of brain dysfunction. They go on to say integrative care is essential. And I was like, thank you very much, because that is what I get to do every single day. Having PT, having OT, having psychology, having neuropsychology, having all of those pieces integrated is key in both disorders, and especially when one might lead to the other. So very important. Okay. I'm going to just put this back up. Here's the article: Post-Concussion Syndrome and Functional Neurological Disorder, Diagnostic Interfaces, Risk Mechanisms, and the Functional Overlay Model. And a review article I shared in this live, some things I didn't agree with, but I shared the things that I really agreed with as well. And I think it's just really worthwhile to see these things together. So I want to answer your questions. Folks had asked questions and really beautiful questions. So I want to answer those. And if you have a question while we're live, let me know. So this person asks, I have FND after concussion and have been to different doctors, but their exercises don't work. Do you have tips for what to look out for, troubleshoot that could possibly prevent exercise from working? Beautiful question. So this is why I think these authors actually suggest integrative care. So, because number one, I don't think there's one particular exercise that is like the thing for anybody, right? If there were, I'd be like a millionaire if I discovered it, but I just don't think there's not. We're way too individual, and how we might have been affected by concussion and developing FND is so different person to person. And what I have found, and this is because I do the consultations for a program. So I meet people every single week who I get to hear their story. I get to understand what their symptoms are and try to piece together a picture of what they might need. By and large, the biggest thing that I hear is that people have tried many, many things. They've tried vision therapy. They've tried PT. They've tried psychology. They've tried acupuncture. They've tried chiropractic. They've tried speech therapy. Oftentimes, and those things are wonderful things. They're great. However, in a disorder where there is a network dysfunction, so parts of the brain overly communicating or underly, that's not a word, but under communicating, when that happens, it's not just like just your eyes or just your arms or just your neck. It is all of the pieces together. And so one of the things that I would suggest, so this was Emma's sad boy was the person who asked this question. What I would look out for is I would look for all you doing things that work systems together. And I'll tell you, two of the biggest pieces that I see missed are the autonomic nervous system and the sensory system. Really, really important. I also see that people might do really, really wonderful rehab but they're actually not able to sleep at all. And let me tell you, sleep is like the magic pill for the brain. That's where all the healing happens. And the authors even talk about sleep dysfunction in this article, just briefly. But if you're doing all the great things, but your brain is not having the ability to actually encode those, like motor learning gets encoded as we sleep, memories get encoded as we sleep. If it's not able to do that, then you're totally missing out, right? And so that is why, like all of our OTs, they are sleep specialists, and we can work on the sleep alongside those other things so that you can actually make those gains. So beautiful, beautiful question. And I see more questions coming up here, and I'm totally going to get to those. But some people sent them ahead, and I wanted to answer those. Phoebe, hi Phoebe. So Phoebe asked, what's the rate of post-concussion syndrome development in people with FND? I don't know. This hasn't been done, Phoebe. I think that is really, really interesting. But that research hasn't been done. So I don't know. I don't see that a lot of people with FND also develop post-concussion symptoms, but I will say if a person has FND and they get a concussion, might they be more likely to have prolonged symptoms? Yes, because of this overlap. Absolutely, because before they hit their head, they already had autonomic dysfunction, or they had sensory difficulties, or they already had this predictive brain phenomena that wasn't getting up, their predictions weren't getting updated clearly, right? They had some attention differences, or these network changes in the brain. It could make your symptoms prolonged, but it doesn't mean that it has to. So I think that's important and a great question. Somebody else asked, like, how can I get to reactive for treatment? We're in Southern California. And we can see people in California for treatment, either online or in person. And we have people come from all over the world to work with us. It's probably like my greatest joy to be able to meet people all over the world. Another question was, had a concussion as a child, no problem. Then, but now as an adult, I have FND connection. We don't know. It's a really, really great question. We don't know if that concussion as a child led to brain changes that predisposed this. We have no idea. Now, will I say like a closer time frame of this? I have seen, right? So a person had concussion, had post-concussion symptoms, developed a functional movement disorder. That I've seen. I have, and the research hasn't shown this either, that a concussion early on would directly cause FND. And again, we don't really know, just like many neurologic disorders, what the exact cause of FND might be. It's multifactorial. So even if that concussion you had as a kiddo potentially made some brain changes, there's likely other pieces, right? And what we do know is that the brain can change and heal and reconnect. And whether you had a concussion as a kiddo or not, there's a lot that is possible in the brain. Let's see. I think I got the questions, but I see so many more coming through, so I'm going to answer them. How can PCS eventually develop into FND? So I talked about this a little bit, and other people ask this question, so it's a really, really good question. So I'm actually going to share another diagram. I share this diagram frequently in FND and in persistent post-concussion symptoms. So when you have a concussion, which many people do, my daughter had one not that long ago, you have a metabolic cascade of events that occur in your brain. Your brain does change. It is a brain injury. It's not a permanent injury, but your brain changes. You have symptoms. And then, the majority of people, they recover and they have no symptoms any longer. And by the way, because there are a couple of biomarkers that you can do acutely after concussion, it doesn't seem to be that people's symptoms are directly related to those biomarkers. So I think that's important component. People's symptoms aren't directly related to how bad the head injury was as well. And I think this is really important because every head injury also includes a neck injury because they're connected. And so sometimes things can be neck related. Okay, so anyway, you have that concussion. Then as you're going through that recovery component, there's a lot of factors that influence it. These factors are very similar between FND and post-concussion. And these were some of those risk factors that they talked about in this article, but also other things. So hypermobility, autonomic dysfunction, being autistic, having ADHD, having a sleep disorder, all of these things influence the recovery process. And what can occur is a lot of, I would say, neuroplasticity gone awry, and you can kind of see this there, this maladaptive neuroplasticity. So if your brain network gets stuck, and that can be in many different ways. So the network dysfunction in FND can look many different ways, but one of those is attention to the body and to symptoms. Now, after you've had a concussion, your doctor, your family, your parents are actually asking you to attend to symptoms. They're asking you to take your attention resources and look inward at your body. Are you dizzy? Are you having a headache? Are you nauseous? All of those things, right? That, in some cases, can actually contribute to development of FND. Not that you caused it yourself, but the brain network shifts out of this salience network into this highly like attention and vigilance, and some of that is autonomic, very sympathetic drive that can influence your movement and your control and your self-agency of your body. I'm going to say that's like the simplified version of how that could occur. And also, we don't fully know, right? So this is like a hypothesis, really. And again, we don't know why a lot of neurologic disorders occur. We don't fully understand it. There's genetic pieces, there's environmental pieces, there's a lot of different pieces that can go into any neurologic disorder. It's not always about like, well, let's find exactly how that occurred, but let's understand what's happening now and how can we unravel that and cause neuroplasticity to really go in a positive direction instead of this maladaptive way. So there's hope in that. That's what I'm saying. Shane, I haven't been concussed since 2011. I was diagnosed with FND in 2022. Would you think they might be connected? So similarly to another question that was asked, I don't know. It's possible, but we don't know. We just don't know. And there wouldn't be a lot of ways to know. Now, much like other neurologic disorders, let's use Parkinson's as kind of an example. Sometimes there's stuff like people get diagnosed with Parkinson's, but they've actually had symptoms for like 5 years, right? So maybe they had this like REM sleep behavior disruptions. Maybe they had a loss of smell, maybe like a slight change in their arm swing, but they weren't actually diagnosed until a particular time. It is quite possible that a person experienced symptoms or very, very little from their concussion and just kind of like carried on or ignored it or what have you, and until it just got to be too much, until those really escalated. Now they're only going to escalate not from the brain injury, but because of other factors influencing it. So if brain injury symptoms the trajectory of brain injury symptoms is to get better. If they are getting worse, there are other factors at play, right? And that could be many things. That could be sleep deprivation. That could be sensory related. It could be autonomic. But it's not because the brain is getting worse. The network connections maybe are going awry, but the brain's not deteriorating. The brain's not like going to mush, although it often feels like it's going to mush. But something's happening in those connections. But the hope in that is that we can change connections. We can absolutely change connection. I am so thirsty. Too much stuff. But I love your question, so thank you. Judy asked, for people with PCS, FND, and associated short-term memory issues, what types of recommendations would you have? I know you mentioned goal-directed activity, but curious how treatment works for daily tasks. Really great question. So, short-term memory issues. This, I think, first requires some like, what's happening there, right? So goal-directed activity is really helpful because it takes the attentional focus off of the symptom or the body, or like squeeze the glutes, like as I go upstairs, right? It gets me instead to like, let me get to the 11th stair. So it frees up brain resources for you to attend to the goal. And when short-term memory is impaired, we want to be able, and sometimes that impairment, now, so this is where testing this out, like the reasoning why, is really important, because sometimes that impairment's actually that the memory never got encoded because of attention. So if we can free up attentional resources, we can better encode some of that memory. And if we're using a lot of resources, and another example I think of is just the person with hypermobility that unconsciously their brain is working in overdrive just to keep their body together, just to keep their joints from subluxing. And I'm not even saying they're like attending to it voluntarily, like the brain is just working because it's not getting really good sensory feedback. And so this is why the person with hypermobility might be predisposed to having more symptoms and developing post-concussion syndrome and FND, because they're already using tremendous brain effort just to keep their body together. And so if we can support their body and voila, like less brain fog. And I'm not saying that that's the case for everybody, but it can really be very beneficial, very powerful for people. So that's the kind of thing that would be in daily tasks, that we shift the attentional focus from body and symptoms to goals and tasks that we're doing to the day. That's why we really work to get people engaged in life, in play, in fun, in joyful activities, because those, I mean, they're also really good for dopamine, which is great for the brain, and for automatic activity and attention and motivation and all of those things. But they give us a shift in our brain resources. What a beautiful question. We have another question. Recovery period for 3PD and migraine. What a great question. So 3PD, persistent perceptual postural dizziness, often overlaps with migraine, particular vestibular migraine, and people can get better. And it really depends on multiple factors. It depends on the whole pie chart, what all is involved, right? Migraine medication can be really helpful for some of those people. But, you know, I had one gentleman that I worked with who had 3PD, no migraine, 5 sessions in about 4 months, and he no longer had symptoms, and he's still really going strong. I've had other people that it's taken a little bit longer. I've had other people that it took a couple years. So this is very, very person specific. One thing I will say is what has been most beneficial for a lot of people, particularly if they've had those symptoms for a long time, is looking at the whole person, like looking at the vestibular pieces, the visual pieces, the sensory pieces, the psychosocial pieces, the lifestyle pieces, the neck, the physical impairments. Looking at all those pieces together can be really, really helpful. I'm so sorry, my throat is getting so dry. Okay, Leah. I'm a physical therapist working with a patient of FND. What are your thoughts on symptom logs to promote self-efficacy? Beautiful question. So, I think this is very person specific, and I really like to shift monitoring the symptoms to monitoring my activity, my joy. Now, I'm not saying let's ignore pain. That's not what I'm saying. And I'm not saying let's fear that either. But if we, like I just talked about the attentional focus, if there's a high attentional focus and logging of symptoms all of the time, you are not spending, you're taking a brain energy to monitor those things. And that is actually sitting in the default mode network of the brain. And we know the default mode network is already like way too ramped up in FND. We want to decrease that. We want to increase salience network. We want to increase connection to goals and activities, because that's how our bodies, brains learned things in the first place, right? But it frees up enormous amounts of energy. So what I would like to focus on, and maybe even log, is how many steps did I take today? Did I go out for a dog walk or not? Monitoring things after they occur, for example. Now, this is my caveat, and they actually talk about this a bit, and I really resonate with this because I'm a perfectionist. So even as I said, like, I want to count my steps, like for me, actually, no. I'm not going to count my steps because I'm a perfectionist. And then I get like really, really like, I must meet this goal. And it actually puts me in a little bit of a vigilant and sympathetic state. And that's not like a really like nice place to be in if I have symptoms of tremor, right? So this is so person specific that like I really want to see like, what would be a balance that really works for this person's personality and their symptoms? They may be a person that doesn't have a really great interoception, and actually looking in and noticing feelings in the body is really helpful. So that could be really helpful for that person and not helpful for another person. Really, really good question. And I had to give you a super nuanced answer there. Okay. Another comment here. I had FND first for decades. I've only had PCS for only the year. I'm autistic and ADHD. This person sharing stress and inflammation, sensory sensitivity management is the key to managing all of it for me. Beautiful. Because you like found out and understood what was helpful for me. And I know because we both read this article and we kind of had a bone to pick on it. They did talk about the overlap with ADHD and autism. They talked about stress, obviously, but I think really left out things like the sensory piece, like the autonomic piece. Again, it's really about what you need, right? So another comment from, is it Soph? Also, somatic work. Yes, neuroflossing, yoga, great, has been the most beneficial for PCS symptoms for me. Helps to regulate the nervous system and the brain eyes. Yes. And what is helpful for you can actually be really not helpful for another person. I share this frequently, but for a lot of folks, they were told like, you should do meditation or you should do yoga. And they do that and their symptoms are worse. Or they do breath work and their symptoms are worse. That's not what their brain and body need. Other people, they need that. But it's not for everybody. And there's very good reasons why that might not be for you. And you need to test it out and figure it out. That's why there's like not a like, do this exercise. Like everybody should do this exercise or everybody should do this activity, because there's just not one that works for everybody. Diane, how do you stop the fear of feeling unbalanced? Oh, when standing from sitting and the fear of 3PD. This is such a good question. Like first, of course you would have fear about being unbalanced and falling, maybe like because that's happened before, or a fear of how it feels when you go to stand if you have 3PD, because you've felt awful, you felt dizzy, you felt nauseous, like all of those things have occurred. So I just want to say it's totally normal that you would be feeling fear in those situations. And I also want to ensure you, like, you won't be there forever. And it's not as simple like, okay, well, just do it and don't feel fear. Like, no, if it was that easy, we would all do that, right? So a lot of this is very carefully, often working with a physical therapist, an occupational therapist, a psychologist, at looking, noticing, and taking some steps along with some control, right? So a lot of times we are experiencing that fear because we haven't had control. So it's finding those pieces. I often call them like a dimmer switch, like where you could turn symptoms down so that you could face something like standing with less fear. And then you find other dimmer switches and you do more and more and more, and you get better. And people with 3PD really get better. But it's kind of kind of a dance. And it's not just like, well, expose, like meaning you just have to try things. You try things, but you have to try things with control. You need to gain some sense of control. And I know that probably feels impossible if you've had 3PD for a very long time. And I've worked with people who've had 3PD for, over 20 years and felt like this would never come back. It is possible. It is possible. So another question, do you think neurofeedback could be useful when trying to balance out the default mode network? Great question. I don't know. And this might also be person specific. So neurofeedback is something that has been studied in small studies. I've seen other patients use it as well as a way to give feedback to the nervous system about what's happening. And some people can find that really beneficial. For other people, it's quite internally focused and could make symptoms worse. And I'm not saying they're worse forever, but it would be something like, and this is what I want to say for concussion, for FND, sometimes you're going to try things and symptoms are going to be worse. You haven't damaged your brain, you flared things, and that is useful information to know. That particular thing was not exactly what you needed. And you might need something else, right? And so if you try neurofeedback and it's not helpful, it might be because it was too internally focused. And again, it's only addressing one piece, right? Shane says it would be a lot easier if we were all the same. Shane, my life would be easier, my job would be easier, and it would be so boring, right? Like, I wouldn't even want to do this. And I have to tell you, this is why as a physical therapist, I got into neurology, because I did my training and then did my clinicals in other realms. And I just was like, even though no two people were the same, I just kind of found it rather boring. The brain, not boring, but the brain, complex and hard. Yes, very. I appreciate that comment so much. Yes. Okay. And then another comment when I was talking about how some things can make things worse. Breath work and meditation and stillness sends me into chaos. Yes. It's like total chaos for some people. And I can't lie on my back. Yes. But for others that works. Physical loading helps me for proprioception. It's all an experiment. I love that perspective. It's a lot of experiment. And this is why, like, as a physical therapist, I can go in and I can help fine tune that experiment, right? Like, we can test things out and go, no, not that. Like, this is where we're going to go, and let's find the right piece for you. So that was great. No wonder it's like we've been over an hour here. No wonder I'm having to drink water. Thank you so very much for these incredible questions that you have asked and comments, and for voting on this particular topic as well. It certainly is an interesting one, and I appreciate you being here with me to just dive into the curiosities of the brain. So thank you so very much. And again, I'll send this out in our newsletter, this video, along with links to the article, and I'll see you again next time. Thanks so much and have a good night.